Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast is to bring you short educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment and the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job in caring for people living with dementia and connecting them and their care partners to the things they need. Well, welcome to Dementia Care on Air, our podcast for Dementia Care Aware. I'm Anna Chodos, your host today, and I'm really thrilled to be joined by my colleagues, Dr. Wagahta Semere and Joseph Herrera. They both presented a fabulous webinar for us on February 7th, 2023, on assessing and connecting with the caregiver. And this conversation today is to summarize some of what we learned during that webinar and go a little further in terms of practical tips and examples of how we can do a better job in primary care as providers, as team members, to connect with caregivers and support them. So by way of more introduction, my colleague, Dr. Wagahta Semere, is an assistant professor at the UCSF Division of General Internal Medicine at Zuckerberg San Francisco General, where I also work. She's a primary care provider and a researcher on how healthcare can engage more with caregivers. We're also joined by Joseph Herrera, a social worker at the University of Southern California, Rancho Los Amigos, California's Alzheimer's Disease Center, and has worked for years with people living with dementia and very much with their caregivers and connecting them to resources. So first off, I just wanted to summarize some of the things I know I learned in our webinar about caregiving. Here in the US, we often have formal and informal caregivers, formal caregivers being people who are paid to provide a formal service around caregiving, but many family and what would often be called informal caregivers who are relatives, partners, friends who provide a broad range of assistance. Could be very practical, physical, directly supporting activities of daily living, but also emotional. And a big take home from our talk and our webinar was that that's often unpaid. It's often unpaid to the tune of $17 billion a year. But the other big things that stuck out about what we learned from you guys was that 80% of people with dementia are receiving care primarily in their homes. So the bulk of care is happening in people's homes. And that for specifically people living with dementia, they're often receiving care for much longer than other conditions. And so really important for us as we go into this conversation, thinking about caregiving for people living with dementia, that the duration is often long. There's a lot of informal caregiving. It's often provided in the home and uncompensated. So thanks for letting me summarize and provide some background on the great talk you give, and a really formal and hearty welcome to you guys. So hello, Wagahta.
Hi.
And hi, Joseph.
Hello.
So Wagahta, I wanted to throw the first question to you. Why do we need to or want to engage family caregivers?
Yeah, that's the big question. I would argue that there are quite a few benefits to engaging family caregivers. I would say that they're just a wealth of knowledge, often untapped knowledge that's right there in the room before our eyes, but we're not as used to seeing them. You know, we talk a lot about caregivers as being hidden patients, and you just went over the stats about the prevalence of caregiving that's happening in dementia. And so really they're right there, but we don't think about them often in terms of how we bring them into the picture of our patient's care. And there are some really tangible benefits that they can provide. So one clear benefit, thinking about care transitions. Often patients are in and out of the hospital with complications related to their dementia. And here you have someone else that can help support that link between when they leave the hospital, when they come back to the office, when you're seeing them in your clinic visit, what really happened, what were some of the changes to their care plan that we now need to consider, and how can we ensure that that happens in the home setting. You're only getting this snapshot in the office, and their care really is happening outside of the office the vast majority of the time. So they can be a crucial link there. And they can also help you to the extent that you're trying to empower your patients to live as long as they can independently with the ability that they're able to do. So kind of engaging your patients in self-management. What can they still do on their own that you want to be able to maintain? And how can you reinforce that with the caregiver that you have? Also, helping to explain the disease, explain what's happening, and the steps in management. Oftentimes, your explanation might not come through as clear as a provider, but hearing it from a loved one, hearing, this is where we're at. It's no longer becoming safe for you to be at home alone, or it's no longer safe for you to do these things that you were once doing. We're having trouble managing this. That can be a partnership in sort of having that conversation with the patient, with the caregiver, and their loved one right there. And on a very practical level, this goes back to the care transitions, preventing adverse events, preventing, mismanagement of medications, forgetting about dose changes, forgetting about stopping things. That's also a place where caregivers can really be critical. And then overall, just the communication piece, I would say I found that you can't emphasize that enough. Oftentimes, I'm caring for a lot of patients with limited English proficiency. It's not always the case that their loved ones are English proficient. In some cases they are. In some cases they might have more health literacy, and that can be an added benefit where you have someone else who can help you bridge some of those communication barriers outside of the clinic setting and in the home as you're sort of navigating those challenges.
Do you have anything to add, Joseph?
No, I would, this is excellent. I would just add that initially, what I do in my relationship with the caregiver is when they are initially given the diagnosis, it's a very painful situation for them. It's a very painful experience. And so it is important to address those feelings that come out of the diagnosis, but also acknowledge that type of relationship that the caregiver may have with a patient, because now there isn't a running away, if you will, from the patient. And so address some of the feelings that they have about the diagnosis, the relationship with the patient, and what they expect of the journey that they're about to embark by providing care to, and this is a word that I usually avoid using, but loved one, because in my experience, the caregiver isn't always in a good relationship or a loving relationship with the patient, which further makes it a little harder to figure out how to develop or how engaged they're going to be. So my work is cut off by figuring out communication styles, relationships, and then try to figure out where we start to develop the care plan so that we can get the right outcomes and the willingness to assume the care and the support for the patient and things that are important to the patient that will be supported for the long run with or by the caregiver.
Yeah, and that kind of ties in a really important point about like it's an additional person and an additional support to sort of process this diagnosis and all that entails. They're obviously going to be affected, and so processing that together. So I think this brings up how we talk to caregivers, and I'm guessing that might depend on your role, if you're the physician or the social worker or even another team member, how you might approach the caregiver or talking with the caregiver. Joseph, how do you approach talking to caregivers?
I guess in our practice, it's a little bit more organic because we do require somebody to accompany the patient at all visits. And so the initial visit or the initial evaluation is 2 hours. And while the neurologist is evaluating the patient, I'm evaluating the caregiver and making observations at the same time. So it's in tandem in the same room. And so I try to assess what the relationship is based on the interactions and then figure out how they are taking the news or whether or not they know that there's something going on. They just don't know what it is. And I've always said that what brings people to the evaluation is not dementia, is not the memory loss, is the behaviors. And the behaviors are one of the most taxing effects of the disease on the caregiver, because the caregiver has a tendency to forget that they forget, and they're well, they're fine, and again, depending on the relationship that they have with the caregiver, um, it's important to figure out how that is either putting a strain on the relationship or the level of stress under which the caregiver is already experiencing. But it is important then, once we get a diagnosis and we have a name for the condition, then to address the realities of the disease and what is expected of the progression, and then try to incorporate or get the buy-in of the caregiver into what the role is going to be. And it's important to note that the caregiver doesn't necessarily came willing into this new role, and it's not just a role, there's multiple roles that they are going to assume because now they're the caregiver, they're the driver, they're the advocate, they're the lawyer, they're the nurse, they're this I mean it's multiple roles into one, that most people are assuming unwillingly. So there is on the medical side is, so this is the diagnosis, this is what we expect to happen with ability, capacity, function, but the role of the social worker that is to address the emotionality and the practicality of providing and devising a care plan that will ensure that both the caregiver and the care receiver are well taken care of and that they maintain the same quality of life to which they're accustomed to, but also incorporate a lot of like self-care and a lot of education about the disease and the importance of caring the caregiver caring for themselves first, if that makes sense.
It does. And one really intriguing thing I think you said, how do you approach them in a neutral way that would allow them to talk about if this is sort of a reluctant role for them or something they weren't expecting or not feeling like they can take on?
Right. So my initial question is, and we sometimes do separate the patient from, well, like when they get into the neurology and their neurological examination and the patient is engaged with the provider. Sometimes I do separate the caregiver or the potential caregiver, and I say potential because a lot of the times we never see that person again, and it's somebody else that assumes that role in the future. Um, so my initial question is, what do you know about dementia? What do you know about Alzheimer's disease? And so see how what they know about the disease, what information they have readily or what they have heard, and ask them what their reaction is to the news or what they just heard or what they think is it's going to happen after the diagnosis. And so I try to address the emotional uh, part of just having or knowing that there's going to be a diagnosis that is not what they expect. Um, And also taking on account the cultural beliefs of the individual and their families. That is very important because um, for a lot of our Latino patients, the first question a lot of the times is, and how long are they going to have this condition? When will they get better? And depending on many factors, including uh, religious beliefs, then they will say, well, we're going to have to pray a little bit more because God gave the disease and he will take the disease. So they start, how do you take the hope away from them from a hopeless situation, right? And that's not my job. My job is to encourage them to do anything that they can to feel better, but also be realistic about what needs to be expected as far as the journey is concerned.
Thank you for sharing that. And I know you work in this really specialized setting. You have a lot of time with folks. Wagahta, I'm wondering in your practice setting, how you approach starting to talk to the caregiver and what kind of barriers you might have to doing that, or, a general practice might have.
The first step, I would say for us, so certainly I would love to have 2 hours to patients, and that's why we work so closely, and it's so helpful to try to find additional supports, like our social workers who can help us in these cases. But in that brief encounter, I think the first step is don't miss the opportunity to ask who's in the room. Can I ask who you brought with you today? What is your relationship to what is the relationship that you guys have, taking that opportunity, even in that snapshot, to start to understand what's the context of the caregiving, if this is their caregiver and the relationship that's happening. Do you live together? Just asking a few quick questions, I think, can help you get some framing around what is happening, and what this relationship is. And then I do find, and not always on the first visit, I'll say, that it can be helpful to separate the caregiver and the patient. And sometimes that can be in the context of, I'm doing a brief exam. Is it okay if I talk to this other person? Getting permission. There are obviously much of the hesitation that providers feel, I find, is around, is it okay for me to talk to this caregiver? So that's also an opportunity to get that verbal confirmation that it's okay, and it's fine to get that verbal confirmation. So once you have that confirmation, you can move forward with potentially separating the two, depending on if you feel like that's needed in that encounter. Sometimes it's not the first encounter. As I mentioned, it might be like the next one as you start to get more information. And if you feel like it's necessary because, as Joseph hinted at, there's some tension or some different dynamics that you're trying to tease out about why, how they've entered into this dyadic relationship, this caregiving relationship. So I find that can be helpful. And then once you have that permission, it's okay to talk to the caregiver, whether or not it's in front of the patient, sometimes in that separate encounter, starting to ask things like, I find that it's really helpful to know a bit about my patient's home situation and understand their caregivers in order to provide better care. How are you feeling? How are you doing right now? And just keeping it very open-ended and broad, and opening that door for them to start to share a bit about how things are going, and seeing where that takes you. And then getting into, how are you coping? How are you coping with this? How are things going for you? But even just those couple of questions, I find, mean so much to the caregiver. And that may be all you have time for in that first visit, but it's a lot. It opens up the door. And I think thinking about it as, I don't have to tackle everything right now, but I can start to understand what's going on. Even in this 15-20 minute visit, I can spend a few minutes recognizing, acknowledging the caregiver. It goes a long way. And I think that it can support the care that you're providing for the patient. And you want to affirm that to both the patient and caregiver, that it's the both of them that are important together.
Thank you. So if I'm going to put it together a little bit, what you guys are both saying, acknowledging that there's a caregiver present, asking, I usually start appointments by saying, talking to the patient and saying, who'd you bring with you or who's in the room was your question, Wagahta. And then what, let's talk a little bit more about what this relationship is and what kind of assistance, is you might help out with, or do you need daily assistance? Okay, does so-and-so provide it, the person who came? So it gets really practical. But then what you were saying is you're starting to pick up as well. And Joseph, in a way, you seem to do this really intuitively, or I would say sort of obliquely, which is starting to talk to them about other things like that we have this condition, diagnosis, dementia, or maybe specifically we already know it's Alzheimer's. How is that going? Kind of what are the needs that both of you have around this? How are they processing it? And then when we sense that maybe there's more conversation that needs to be had with either or both privately, finding those moments to separate them and have those conversations. And I also often take advantage of the physical exam moment to say, I just want to do a physical exam. I'm going to invite you to wait in the waiting room. I'll bring you back. And then I can often try to find another room or a few moments somewhere away from the patient to talk with the caregiver. And they might be able to say things they don't feel comfortable saying in front of the person they're caring for, and vice versa, asking the person who's getting care how things are going. I think the other thing you brought up, Joseph, that was really important is this issue that people don't always have the same caregiver, or there's sort of a rotating cast, or things shake out once more needs start to evolve or behaviors really start to play a bigger role. So we may have this opportunity more than once to have these conversations and reassess and point out that we're thinking about it. We're assessing it. We're trying to get information about the relationship and how we can add supports. I think the next questions I have are, how then do we start a care plan, or what are we thinking about? And Wagahta, I don't know if you could start us off on that.
Yeah, I think I would say we've started to talk about some of the ways that we develop that plan of care, kind of how we assess the caregiver. And that first one is really understanding what is the caregiving context, what's actually happening, how did you enter into this caregiving role, how do you provide care, those very practical questions. What do you help with? What is your role? Because it varies on the spectrum. What are the specific tasks you're doing? And I like, Anna, how you talked about that. We really do want to get as specific as like, what are the ADLs? What are the other things that you do financially, coming to appointments? All of that helps, and that will tease out if there are other people involved, hopefully as well. And then, as Joseph, I think, highlighted, it's so important to understand, what does the caregiver know about this care recipient's health and functioning, their diagnosis? What do you understand about what's happening, what is about to happen? Because that's really the first step for moving forward. And then a little bit more about the caregiver's personal kind of context. What do they bring to this? Their values. Why are they in this role? Why might they stay in this role? Why might they leave this role? So that you can plan. And once you have a better understanding of that, like what brings them joy, what's challenging about being a caregiver, you can start to, I feel, assess how they're doing and start to understand their well-being a bit better. And then from that, understand, what do they need to do this caregiving role? Like, what concrete resources can we provide you? Where are there the gaps? What unmet needs are you having? I think that's where the conversation hopefully naturally kind of goes in the next steps, once you've gotten to know them and assess them better and this caregiving role.
Joseph, that sounds like a clear path to you. How do you start to support folks?
So one of the first things that I do is ask if they have a power of attorney, because I have to be very careful with what information I share with the caregiver and whether or not the patient is okay with that information being shared. So once and we provide a document that is given to us by Beth Zedek, we actually have a very close connection with the lawyers at Bethzetic, and they have designed a power of attorney that incorporates everything that is possibly needed, and it's good in the entire state of California. And so I sit down with the patient, and the focus of the attention for me initially is always the patient and what the patient is comfortable with. And because a lot of them, they say, well, please don't tell my daughter that I have dementia. Or please don't tell my husband I have dementia. And don't tell my partner, or don't tell my children, right? And so we have to respect that. Of course, the family may already know that there is something going on cognitively, and they have noticed a lot of the behaviors, but I think it's important to have those conversations with the patient and make them feel comfortable and start building that relationship. And so, is it okay to speak to your daughter, to your son, to your children about this? And then they sort of filter what we can share or not. But then we talk about the power of attorney and the future needs. And so once they give the permission, then I can certainly engage the caregiver or other members of the family and share information. And then start the process of processing their angst about the disease itself and the new diagnosis or the confirmation for them, for some of them, and then figure out, what do you need immediately? What do you need midterm? And as the disease progresses, what do you need to prepare and anticipate the late stages of the disease, including death? But it's important to talk about the fatality of the disease as well, and how the needs are going to evolve. So start, with the first step. What do you need today?
Thank you. And so what I heard you guys say is we're really looking to see what immediate needs there are. We're thinking longer term planning and help guide them anticipatorily around that, like the DPOA issues, other legal needs, and then all the way to the fact that this is a terminal illness if something else doesn't happen. So thank you for all those fabulous nuggets. I think we just want to briefly chat about something that's brought up all the time, especially in the context of caregiving for someone with dementia, which is caregiver burden. So I'm wondering if, Wagahta, if you can give a quick review of how you would assess for caregiver burden.
Sure. So I think it's one of the things that gets a lot of attention because we worry about it so much. And a lot of the stats that you pointed out, especially in dementia caregiving, it is a role that is really set up for being at risk for burden. We know that many spouses are caregivers. We know that they're providing care for longer duration, more hours, and things that put them at risk for burden in complex situations that involve, as Joseph pointed out, behavioral conditions and things that really contribute to burden. So really, I think it's understanding what burden is, and it's essentially the caregiving role affecting other parts of the caregiver's life. How does it impact their physical, mental, and emotional well-being, and the other responsibilities that they have, and broadly understanding that. And really, I just, ask those questions indirectly. There are tools, and we talked about this in the webinar. One of the really accessible tools, if you want something objective to track and measure, is the Zaret Burden 4, just as kind of a quick 4-item screener. But essentially what that gets at is, how is caregiving affecting your other responsibilities in your life? Do you feel stressed by caregiving? How is it affecting your emotional well-being? And those are questions that you can naturally ask caregivers and start to understand if they're at risk for burden. And from there, you'll want to think about how you can start to address that burden. But often it's just picking it up and asking those questions that can make a huge difference and mean a lot.
Joseph, any tips on addressing caregiver burden?
Yes, I think all of those things that Dr. Semere mentioned are very, very important because you want to make sure that the caregiver is well enough to take care of the patient, right? Um, but as a social worker, the most important part is the relationship that you build and that trust that you build. Because a lot of the times we notice that the patient may be a little combative, a little aggressive, a little agitated, and the caregiver endures, right? So how are you feeling today? Are you stressed? Are you depressed? Oh no, I'm used to that. So you're not depressed at all, but you can see the body responses, right? So then, especially in Latino families, we start talking about depression. No, and because Latinos don't get depressed, right? And don't go around saying that Latinos get depressed because you're giving us a bad name. We don't have any mental health issues. But then when I sort of start talking about, are you eating? Are you overeating? Are you sleeping? Are you oversleeping? What is your level of energy? Then I get all the responses, which fit very neatly into the depression and anxiety category. So teasing out those things are important. And I think that caregivers want to hear that they are understood, that they are heard, and that you understand as a physician, or you understand as a healthcare provider well, you don't know exactly what they're going through. Some sort of acknowledgement that they are important in this diet as well. And that opens up the gate for you to start providing resources. So it's important that we, as providers, maintain our thumb and a pulse and how they're doing, because the better outcomes for the patient, or what is expected of the caregiver in relationship to the patient, it puts a huge burden on them, because the fact that they see us as the authority, right? Well, you're telling me I do this, I have to do this regardless, and at the cost of my own personal well-being.
Yeah, those are really important reminders. I think it's hard to know sometimes how to really bring people back to themselves and give them the time and space to, as you point out, not be so consumed with the caregiving role, but keep bringing them back to the resources that are available, keep making it something that's important and validating that it's something they could do. That sounds like at least some of the work that we can do. And we'll definitely refer people to the resources that you guys mentioned during the webinar, and that we also are getting up on our website so that people can find those resources to then refer patients and caregivers to. Well, thank you guys so much. This was a really rich conversation. I just want to thank you guys so much for lending your experience and your expertise to this conversation. Thank you so much.
Thank you.
Thank you, Anna.
Thank you for listening, and to our wonderful guests. And a big thank you to our administrator and everything doer, Rita Archikova. Also, thank you to our audio editor and voice specialist, Lisa Costello. And we want to make sure you know you can get CE, CME, and MOC credits if you go to our website and click through to the podcast page, where you can do a quick quiz to claim credit. This is all possible through support from the California Department of Healthcare Services and the hard work of the Dementia CareAware team. If you want to learn more, please visit our website, dementiacareaware.org.